I'm going to share with you some of my worldview, and therefore, since many of you are researchers, you know there are biases and confounding variables. I want to tell you a little bit very shortly about myself so that as I present my ideas and my story and some of the stories that I try to convey and pass on to our learners, that you will get a sense of where I'm coming from. Number one, I'm 66 years old. Number two, I have experienced pain in many different realms. Neuropathic pain with the trigeminal nerve. I've given birth to 2 children. I've also had the usual aches and pains of growing old. Hand in hand with that, I have lost people who I have loved, and I have had changes in my life where my identity has had to be reconsidered and rethought about. So I've experienced pain on many, many levels, including watching other people who I love suffer from pain, going through the medical healthcare system, not being heard. I started medicine back in 1974, back when the dinosaurs roamed. And the ideas about pain, treating pain, the mythology around pain was such that I actually saw how the healthcare system treated pain in my mother, who had a chronic immune illness with a lot of pain. My mother adored me. My mother honored me. My mother and father respected me. Yet during one of her very acute episodes of her condition, told me, and I was a medical student at that time, said, I would sell you for a shot of Demerol. I have never forgotten that. It was so impressive. She didn't scream and holler at me. She was not there weeping. Her blood pressure was not up. But she was trying to convey to me, because she could not convey to other people, how much it hurt. It hurt so much that my love for you has moved me into a point that I would sell you for a shot of Demerol. And Demerol was used very much in those days, and opioids were just really shunned. Okay, some of my biases. I also have been in public health, so I see the world and I see pain as a public health issue, and I've also worked for 21 years in the Indian Health Service out here in this part of the world. Now I am certified in hospice and palliative medicine, which has a large component in pain. So these are some of my biases. So what I'm going to speak to you about is through my eyes, my experience, my colleagues' experience in the ground floor of trying to pass on what we call knowledge, which is constantly shifting, not truths, but knowledge that is embedded in our culture right now about pain at the medical school level with students, residents, and fellows. Dr. Katzman, who's here, will speak more about other training programs. Thank you. So I call this painful growth. I'm going to throw out very few statistics, very few, but as a clinician and as an educator, these statistics have meaning to me. Again, close to 30% of in our country have pain, and I want you to look at the issues of who feels it more, or when they describe it. If you earn less than $30,000, you see that more people will report that they have pain, and then how it affects their quality of life. These are statistics that are important to me. These are some of the objectives. Being an educator, I always like to give you an idea of what I'm going to cover, and in the end, you can agree or disagree whether I've done that and if it was important to you, but we're going to go through some of these. Everybody's going to be referring to this IOM recent report. This is my only one, and this is what hits me as a clinician. There are lots of people out there, and the last line, whatever in terms of what we see are they're undertreated or not at all. I'm going to use the word chronic pain, though I have some discomfort with it. In our society, because of our culture, sometimes when we use the word chronic, we think that somebody's, faking it. So sometimes I like to use the word persistent pain, but it has not been as dominant in the literature. So I'll use chronic today. But I'd like to leave it open in terms of how we even label conditions. Sometimes we say someone's chronic. They're coming in here over and over again. So I really like that. All right, we know these statistics. We're going to go through these quickly. And in terms of education, I like to try to start to differentiate that pain comes in many different forms with many kinds of conditions. Special populations, as a clinician, we are now much more comfortable talking about pain with cancer. Nursing homes. We have a whole bunch of people who are getting old, right here. Okay, many of them are in nursing homes. A lot of them are very hidden, but if you ask them, are they in pain? I'm talking about pain that is 5 and greater. 50%, there has studies they're showing, they have pain. Elders who walk into a senior health clinic, and myself, they will report pain if you ask, and children with cancer. We are also becoming aware as a society and as a medical institutions that children have pain. Premature babies had pain. It wasn't so long ago that our knowledge base told us that premature babies or neonates had immature neurological systems, and therefore we could operate on them without either anesthesia or pain medication. And I'm talking, this is within our lifetimes. So that we thought our knowledge base from our research said they can't possibly feel pain because they aren't fully developed. And we did things, and we have learned since then that a premature baby does have pain, does need opioids, especially depending on their conditions. And we could talk about my grandson was just recently circumcised, chosen by his parents to do that. It's an elective procedure nowadays among many people for many reasons. And I noticed, which was different from when my son was circumcised 34 years ago, they used 2 components to reduce the pain, a topical and an injectable, and they waited till it took hold before they did the procedure. When my son was circumcised, nothing. He survived, 8 days old. He's forgiven me long time since that. But I'm trying to tell you that these things are very cultural, a lot of them. All right, lots of examples of non-malignant pain. And in teaching, what is becoming more and more evident that when we talk about pain, it's a mixed component. It's not all the same thing. And also this thing in red here, depression. Depression. When I went to medical school, which was pre-1990, this was some of the stories, some of the knowledge base that I was taught. That people are psychologically off kilter somehow, and that's why they have persistent pain. There's something wrong up here, and so I should make sure that they're all tested. They must all go to psychiatrists to figure out why they have their persistent pain. I was taught to make sure that it was real. I was also taught that opioids were not effective, and I should be very wary of them. Lots of prohibition against the use, and pain doesn't kill. And I've heard that recently again, and you just learn to live with it. I was a medical student, 1970s. Since 1995, we've gotten a little more knowledge base, and some of the things have changed. We're now looking at chronic pain as a pathological process that can move into and can be a disease process unto itself. This is a big shift, that people who experience these chronic pain issues are not, quote unquote, nuts. They might struggle with emotional pain that goes hand in hand with it. And yes, people who do have mental diagnoses can also have pain. But just because you have pain does not mean you have a mental diagnosis. It might lead to additional mental suffering. Now we have much more legislation and policy boards around opioids. And I think one of the most fascinating things that we're learning more and more, and I hope this is where you're going to help us, that if we don't treat pain, acute pain, or we don't go after it aggressively when it first comes up or try to prevent it, it moves into a chronic condition. Now, we could all discuss these and argue about them, but that's the kind of information that we have now. So where are our gaps? If you look at it, here's some of them. How do we assess it? You could read. I don't have to read these things. These are our gaps. Very simple. You know them all. And this is an amazing quote that I always thought. Pain has a huge cultural overload. Huge. And I'm hoping that you as researchers too, because as clinicians, we put a huge cultural overload, that as you do your research, you take a hard look at yourself. When you design your studies and what you're looking for, that you leave it open to what you're going to find. I mean, you can have your theories, but a huge cultural overload. And we have here, again, with other reports, this idea of the fear of opioids, and this term narcotics, which continues to be incorporated in medicine. It's a legal term. Narcotics comes from narcosis, making you tired. There's lots of things that make you tired. Go get yourself an antihistamine. Go get you an over-the-counter cold medicine. And yet they're not called a narcotic. Yet we continue to call a lot of pain medications narcotics, and so the cultural overload that helps, that is tied into that in terms of when we go for treatment, and a very real fear, and it's real. Some of these medications, some people can display addiction. And we're learning more and more about addiction, which has gone through a whole series of research. But as clinicians and providers out there who need to treat pain, and with what kind of medications we have, the fear of addiction and the fear of legal action is still there. Even though we continue to try to educate in terms of the proper way of using these medications. So, from that report, it's mainly on how pain is perceived and how healthcare providers and people deal with it, this huge cultural overload. And you as researchers, we're hoping more and more you will be able to bolster us, be able to illuminate for us things that we can share with the public and that we can share with people who are struggling to overcome some of these cultural barriers. Number one thing, and you're right in here, there's no standard assessment. Pain assessment is asking and accepting. That's where we are right now. Same thing. When a crime is committed and there's an eyewitness, this is fascinating culturally, and there's an eyewitness. We honor the eyewitness and say, hey, tell me what you saw, and then we convict people based on that. And we know there's a great deal of error in using eyewitnesses because of how we process things in short-term memory and long-term memory. But yet we do a lot of stuff based on people telling us they saw something. Also, when we ask somebody to tell us the truth, do we have any way to measure that? We have a lie detector test. How effective is that? Yet, when we ask people to be truthful and make statements about truth and swearing on books that they're telling us the truth, we're sort of more accepting of that than accepting that somebody says has pain. Isn't that fascinating about culture? We are the human being, the Homo sapien, is fascinating. And I go back again to how much pain we can tolerate in someone else. So again, our assessment is at this: we have to ask, and many times we don't even ask. And so we use these tools. If we should choose to ask, we have tools like this. Please look at this. Tell me where you say you are. Visual tools, 0 to 1. For children and other people, take a look at these faces, or verbally tell me where you are on the scale. Or we have descriptions. Please describe it to us. Tell us, and then we try to figure out whether it's nociceptive or neuropathic or visceral, or This is what we have now. There's been some MRI studies, and I don't know how to evaluate them. You will need to help me with that, more so. And with your imaging studies, if you are able to actually see pain progressing through the brain, if we can get something that helps us assess pain and get over that huge cultural bump of not believing, when somebody tells us they're in pain of 10, they have a rating scale out of 0 to 10, they are at a 7, and they're sitting there and they're not crying, their blood pressure is not up, they're not begging you, they're able to get up and walk to the bathroom, and they're telling me they're a 7. And I need to either believe them or not. Am I going to believe the eyewitness? Are they telling the truth? Do we have any things to show that? We need other people to help us figure out, is there another way to measure pain, or we're going to stay in this cycle. We also have things like this for people who can't speak and tell us anything. It can be used for infants. It can be used for people with dementia. We have a bunch of these. They're not all validated, but these are the best tools we have. Please look at this person. Tell me where you think they are. Put it into a number. So we're trying real hard to figure this out, but none of them are perfect. And as long as we don't have a good assessment tool, evidence-based, we're still going to struggle. And then we have ideas of what pain is. Pain to you might be not different than pain to me. My bias is, as you can tell, is that I see pain as a total pain concept. And many of you who are working as clinicians to care for people in pain, sometimes you focus on one, sometimes you focus on two, sometimes you focus on all three, and you could throw all the opioid in the world you want, or pain medication at somebody who is struggling with this or their social issues, and it won't touch them. So again, how do we see pain? Tell me about time. We have many ways to manage pain. Am I doing all right? And I know you're educated on these things. But I was asked to move a little more. So again, if you have a belief system and you're willing to see the world that pain has many facets, then your options as a clinician or a provider is to do that. Right now we have the World Health Organization, and these things keep changing on how to use medications, and I was asked to start to hone in on opioids a little bit today. I'm not going to give you the graduate level 5-hour, 6-hour lecture on a lot of these, give you broad concepts. This will change over time. It has to change over time because knowledge changes. But right now, if somebody has a low score, what we call 0 to 4, on 0 to 10, we're going to start out without an opioid. We're going to use other things. See how it works. Give you an idea in terms of treatment. If this works, we don't go any further. And they're able to manage their pain. But if their pain is not reduced, then we're going to start moving to an opioid. and other adjuvant, such as antidepressants and anticonvulsants, until they tell us, and what we aim for, another big principle in pain management, is you never can get rid of it 100%, especially for chronic. We would like to. I'm hoping that down the road we will be able to. But in the experience of clinicians, we cannot promise, if you're real honest with people, to remove your pain to zero. We really try to be honest and say, we want to move it down below 5, whatever you call 5. We want it to get down between 0 and 4 because you have been telling us, you as the general human population, that if we could get it between 0 and 4, and we want to work with you and all these things, you can have a quality of life where you can enjoy life, where you could get out of bed, where you could be active. But once you start hitting 5, it's going to start draining on you. And once you hit 7, 8, 9, or 10, hey, 8, 9, and 10 are emergencies. So another thing is we're going to go up these steps. We're going to try. And I bet this thing will shift as we learn more and more. But this is what we're using now. And then the third stage is we keep going up. And this is what makes a lot of people nervous about opioids. Is that, and I'm going to stay with opioid, you can go up on your anticonvulsants, on your antidepressants. You can keep going up, but you can go up with your opioid too. Keep going the other way. Judy, I'm not going to go into big details on all of these because I know you can read and you probably know more than I do on some of these. But we do have options in terms of pain relief, the non-opioids. Don't throw away your acetaminophen or your what we call aspirin. So let me share with you, these drugs kill more people than the opioids. Number-wise, I'm not making this up, and I don't want you to put opioids in the drinking water. I just want you to balance information. In terms of numbers of people who die from Tylenol overdose, they're greater than opioid overdose. I'm not saying we don't have a problem with opioids. And people have trouble with aspirins. Same thing. People with NSAIDs, the complications that have to do with their guts or their kidneys or their livers. Then we have the different kinds of opioids. Morphine's the gold standard. And then we've made our own. We concocted the bunches in the laboratories. And then, most important is because we don't know enough. We really don't know enough about all the mechanisms for pain, and that's why we need you looking at all kinds of other ways. We use anticonvulsants, antidepressants, muscle relaxants, Botox, migraine-specific, anything. We try to sort of throw it in there. We really do. We try our best. The concept is one drug's not going to do it for everything because we don't know enough yet. Aha, isn't that a pretty picture? Now remember, I'm going to give a balance. Who knows what that is? That's a poppy pod. Aha. Poppy seeds, these seeds have been found, opioid seeds, opium seeds, have been found archaeologically in graves 2,000 years ago, 2,500 years ago. We have opioid receptors. I'm going to say something you might not agree with me. I do feel that in the evolution, plants and animals and all kinds of things have moved together. And one of the most successful growing plant in our world today is this. And it's growing in Afghanistan, and it's growing in Turkey, and it's growing in India, and it's caused a lot of wars. But it's very successful. That's because human beings have found it useful. 5 minutes. Okay. It's there with us. Here are some of the benefits. When I think of pain, especially with persistent, it does control. It improves quality of life. There's no upper limits. I don't want you to go in there and just shoot someone up. You need to learn how to do it. At this point, no major evidence of toxicity. This is why it's been with us for a long time. It has side effects. You know that. Here they are. Here's some of them. It's not all inclusive. Some we are very, very upset about. Some we can handle. And we always know they're going to sedate you and affect the respiratory system, but we have to do it in a way slowly so it doesn't. Other guidelines we use in using opioids, we're going to start if the pain is 4 over 10. Start low, go slow, and you can see this. This is the science of opioid management now. You do it around the clock. You do not have troughs. With pain, you want a medication that does not have you going up. In other words, you have pain and then you go up, and you have pain control and then you drop back down to pain again. We want a steady state around the clock. We don't want this up and down, and we'll give you medication for breakthrough. The idea also that there are many kinds and choices of opioids, and that we could go from one to the other, and we can continue to try to see how the individual goes with this. I want to show you here, and this is one thing with how you dose these things, and you don't have to know all the details, and one of the mistakes is when a person has pain, you give them something, but they do not get relief, and they ask for more. We have to be very careful to make sure that we're giving them enough. You don't just give them a little 10% more or 5% more to get a change. Look at this. If a person is in moderate pain, you have to increase the dosage 25 to 50%. And if they're in severe pain, you have to really dose them more. They're not just asking for more. This is the pharmacology. I won't go into this. We could go from opioid to opioids. We do have to take care of them in terms of nausea and vomiting and constipation. We have to know their biological underlying diseases. I have a sense you all know these terms. And we are trying very hard to pass on the difference between tolerance, which the body will start to adapt, physical dependence. We will all become physically dependent on drugs, and especially opioids if we keep them in our body for any time, and the confusion with addiction. And more, the community is talking about addiction as a behavioral, psychosocial, and pharmacological issue, not just withdrawal. We talk about non-addictive behavior with opioids as they get better, not worse, when they use them. And this is sometimes what we see on the clinical behavior is that people will keep asking. We could create behavior where people look like they're addicted. We don't treat them with the appropriate regimes, and therefore they keep asking us. I'm going to leave it here. You're going to end up with a talk about ethics. This is a physician ethicist. We must honor the fact that people do have addictions and that it is an illness. It's detrimental to them in society. The question is, how do we balance that in our society with the undertreatment of pain? End of life very, very quickly. And pain is a major component of dying. Nobody likes to hear that. How many of you want to die in your sleep? Most of you will not. I don't mean to be mean. That's not how people die in America. So while you're living through your dying, which is what we would like to try to improve, we need to deal with pain and palliative care, and you will have this, again, is an approach. You don't have to be a palliative care specialist, but we do want to relieve suffering and pain. And I leave you with this quote. You are going to be able to help us with these. I'm going to stop. And I do think Angie's list is going to do more for pain education and for changing our societal culture. Very nice article, very balanced, than most of the medical schools. Because the consumer is going to start pushing this.
So we have time for one or two questions. Did anybody have a question for Dr. Kitzes?
Or disagree. I prefer you disagree or say, what are you talking about?
So I have a question for you. So what can be done to help physicians change their understanding of chronic pain as a chronic disease process, as an ongoing disease process?
Physicians now are being told to be evidence-based. We need you to give us the evidence. So in the training, we need you to do studies that are hard to refute, well-designed studies that demonstrate, or at least as you see it, an inflammatory process, to be able to show how you can see it so that they can incorporate that into their learning. Now, that's not a guarantee because we know that many people, even though you give them the data, will not change their behavior. That happened with ulcers of the stomach. Took 10 to 15 years. So, but it's a good beginning. So don't give up. Even though you have the data and you know the data is there, keep pushing it out to us.